Dr. Silva, and tonight I'm going to talk to you about personality disorders. This playlist is all about personality disorders as defined by the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. I want to mention that in prior editions, when I was in training, there was a different classification system. Diagnoses in psychiatry were divided into 5 axes. And the first axis was the diagnosis, but certain diagnoses, the ones that were developmental in nature, that had their onset in childhood or adolescence, or that involved personality disorders, character pathology, which are required to start at the very latest in early adulthood, but usually by adolescence, those diagnoses went on axis 2. And so axis 2, quote unquote, that was a shorthand way of saying this is a personality disorder, this is character pathology. This is mainly a problem with that person's behavior due to emotionality that is perturbed. And the diagnoses were, and just to be complete, axis 3 were physical diagnoses, non-psychiatric diagnoses, especially those that related to axis 1. So for example, hypothyroidism, which might relate to depression due to a medical condition on axis 1. And then axis 4 were the psychosocial stressors, and axis 5 was the Global Assessment of Functioning score, GAF, from 0 to 100, with 100 being normal. And it was operationalized, and each level had a certain definition. But we did away with all that, thank goodness. We did away with all that nonsense. And a good psychiatric evaluation is going to address the psychosocial variables, and it's going to talk about the person's overall level of functioning, and it's going to have all those elements, all the diagnoses. There's really no reason to separate diagnoses out. So now we just diagnose, and we don't sequester the personality disorders into any axis. But they are clustered. And so of the recognized personality disorders, there's clusters A, B, and C. Cluster A is sort of the weird cluster. Weird, that's not official. But it includes paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. And I'm going to have a video on each one of these, but basically you have increasing levels of psychosis. Paranoid personality is very suspicious and distrusting of other people. The schizoid personality has a sort of strange ideas and a restricted affect. Their affect isn't right. They're not delusional, they're not psychotic, but they are prone to it, and their social relationships are not normal. And then you have schizotypal, which is the schizophreniform illness. It's not schizophrenia, it's not full-blown schizophrenia, but those people have eccentricities of behavior and odd ideas, and they could certainly have magical thinking or actual delusions. That's that cluster. I'm going to go into detail with all these, but cluster B is the dramatic cluster, famously borderline personality, which is an unstable self-image and chaotic interpersonal relationships and unregulated emotionality. Those patients attempt suicide a lot, and they're just very unstable, unhappy individuals. And then you have also in that cluster antisocial personality disorder. I've already done a video on that. They're not so much dramatic, but they're in that cluster. They lack empathy and they violate the rights of others. That's the core features of that. And then you have narcissistic personality disorder. They also lack empathy, but they lack self-awareness. And because they have very low, very fragile self-esteem, they engage in reaction formation, a defense mechanism, unconscious defense mechanism that causes them to express grandiosity and have a constant need for approval. And it's a very interesting defense mechanism, how they take that insecurity and that lack of self-image and they turn it into just the opposite. And you also have the histrionic personality disorder, and not talk about dramatic. They are attention seekers, and sort of the prototype is the Southern Belle, Scarlett O'Hara, flirting with everybody and just needing to be the center of attention and being very dramatic. And cluster C is the avoidant, the dependent, and the obsessive compulsive personality disorders. And so they're sort of the worried. Again, I'll go into detail on all these, but that is what this playlist is about. And right now, just briefly, I'm going to talk about what we used to call personality disorder, NOS, not otherwise specified. That was another thing that was removed from the Diagnostic and Statistical Manual. We had diagnoses where it was sort of a wastebasket. It was depression, but you couldn't figure out which type. It didn't really fit any of the diagnostic paradigms very well, and you didn't know the etiology. And so you would just say the depression NOS, depression not otherwise specified, or anxiety not otherwise specified, or whatever it is, not otherwise specified, no specifiers. And those were sort of catch-all diagnoses. And so there was a personality disorder, NOS, that became general personality disorder. So we're saying that there's something wrong according to the criteria I'm about to give you, but it's not as specific as the examples that I just gave from the various personality disorders that are well defined and that are clustered in. Those are just categories to help us understand that they have similarities, but they don't necessarily have shared etiologies. And we don't really know what the etiology is of these conditions. It's almost certainly multifactorial, nature and nurture, a strong genetic predisposition to behave in certain ways, and then if you couple that with the right environment when the child is being reared, and then you can get this personality disorder. And for example, narcissists, if they have children, they tend to, a lot of times their children have an increased risk of being narcissists themselves. And it's because if your mom is a narcissist and you're just an accessory to her, it's always all about her, and she can't mother you because she lacks the basic empathy that a mother should have. And so you're sort of an adornment. She might show you off and cuddle you, but it's because you make her look good to her friends. And then later in life, she's jealous of you and competes with you, and she's not a mother to you. She's a frenemy. And this is just an example. And so if you don't get that unconditional love when you're very little, then you're in danger of developing a very fragile self-image that then you might deal with by engaging in reaction formation, turning it into the opposite, and imagining yourself to be something very special, something that you're not, annoying other people with your grandiosity and your entitlement, and you lack empathy because you never learned it for yourself. You never learned to love yourself. And so you're a very toxic person in relationships. But my point is that a lot of times children of narcissists do not grow up to be narcissists. They are scarred by that childhood, and they have to somehow forge a healthy adult relationship with that parent. If, in fact, the relationship still exists, there may not be the possibility of a relationship if it's really severe. I had a patient that was an obstetrician, and she was estranged from her mother because she just couldn't handle it anymore. The mom was just acting out, and it was just made the relationship impossible. So she overcame it and did not become a narcissist, even though statistically she would have been at greater risk. So that's the nurture piece. But regardless, what criteria do you have to meet generally to have a personality disorder, which I also call character pathology? So I don't say access to anymore, but when I say that a patient has character pathology, then I am alluding to a personality disorder, and that I may not be naming that personality disorder, but it at least meets these general criteria. And they are, first of all, a personality disorder is what? It's an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture. And it's manifested by two or more of the following: cognition, ways of perceiving and interpreting themselves, other people, events; affectivity, their affect, their expressions, how they express their emotions, and that includes range, intensity, and stability, which we call lability. So you might say that a person's affect is labile if it's not stable. 1 minute they're angry, and the next minute they're laughing, and the next minute maybe they're crying. And you could see that in histrionic personality disorder, for example, or borderline personality disorder. And we also rate the appropriateness of the emotional response. And interpersonal functioning, so how are they in relationships and how do they relate to other people, and impulse control. So you see this pattern that's enduring, that's pervasive, that's maladaptive, and it involves two or more of the following: cognition, affectivity, interpersonal relationships, and impulse control. Also, another criterion for a general personality disorder is that this enduring pattern is inflexible and pervasive across a broad range of personal and social situations. So you don't just see it at work, you don't just see it in the context of this relationship or when they're in this particular circumstance. It is across the board. Also, this pattern, this enduring pattern, has to lead to clinically significant distress or impairment. So what does that mean? Like any diagnosis, it has to lead to problems. It has to be distressing, if not distressing to the individual patient, distressing to others. You can have symptoms, for example, symptoms of obsessive compulsive disorder, neatness and cleanliness and being organized and being a control freak, etc. But if you're happy with it and it's not maladaptive and it's in fact helping you at work and nobody else is bothered by it, then they're symptoms. Well, you could argue that they're not symptoms because they're just findings. They are consistent with obsessive compulsive disorder, and for other people they may be symptoms because other people have a different context and different relationships or a more severe situation. But if it's not leading to clinically significant distress or impairment, then you can't say that it's a disorder. Maybe they have a condition, but it's arguable. It's not just semantics. It really has to be a problem. What is clinically significant? Clinically significant means it requires treatment. So they present for treatment or their family is demanding that they go get help. They're not having problems. And you could have two people that have the same symptoms with the same severity, but because this person is married and has co-workers driving everybody crazy, that person may qualify for a disorder diagnosis, where this other person who might be kind of a loner, lives alone, isn't married, and in their little bubble, in their little world, they're not bothering anybody. Their cats don't mind. In fact, cats are obsessive compulsive themselves. I'm going to do a video on that. It's going to be fun. Look for it in this playlist, why cats are obsessive compulsive. But so you can have the exact same symptoms, the same severity, the same patient, really. And if you put them in different contexts, over here, it's clinically significant. Over here, it's not clinically significant. So isn't that interesting that it's a disorder? In this context, it's not a disorder over here. And you can just go back to the very first criterion, which says that their behavior is not acceptable. It's not normal for their culture. So you also have to look at the cultural milieu. The context does indeed determine whether we call it a disorder or not. Next, the pattern is stable and of long duration, and its onset can be traced back to adolescence or at the latest early adulthood. You see the seeds of this, I think, in the cradle and the temperament of the infant. But definitely by adolescence, in the vast majority of cases, you see if they're going to be drama queens, they're drama queens. If they're going to be sociopaths, psychopaths, you see that by adolescence and certainly by early adulthood. So personality disorder is not something that shows up in middle age. Also, the enduring pattern is not better explained by or a manifestation of or a consequence of another mental disorder. And likewise, the pattern is not attributable to the physiological effects of a substance, a drug or a medication, or another medical condition. You can't say that's a personality disorder. At best, you can say it is an alcohol-induced personality disorder. According to the DSM-5, because alcohol is causing it, it's not a personality disorder per se. It shows up when they're drunk, so I would consider that a substance-induced personality disorder. And then it also can't be due to another medical condition, such as, for example, head trauma. A person is fine, and then they get head trauma, their personality changes, or, for example, they develop dementia. We often see personality changes when a person develops dementia. Disinhibition, sometimes patients become very violent, sometimes they become hypersexual or sexually inappropriate. Those can be explained by something that happened, and that could happen in late life. So that's not a personality disorder either. It's pretty easy to diagnose personality disorders and to not make the mistake of not picking up on the fact that it's always when they're coked up or when they got sick with cancer, brain cancer, that sort of thing. We know that that's not a personality disorder. Personality disorders, you see them coming. They cause chaos. It's very disruptive to their lives and the lives of anybody within their sphere. And so a lot of times the chief complaints are coming from the friends and family. So anyway, that is general personality disorder. Please check out the other videos in this playlist. They are fascinating.